If you see the facial height, the lower facial third is reduced. That means there will be a lot of missing tooth or severe attrition where the deepening of the nasolabial fold. So this is the regular smile taken correctly. Very wide smile, showing gummy smile in the molars, premolars. By nature itself, the patient is having this kind of smile, or they might have supraerupted. Okay. So the lower lip smile curve now, and you can see missing to one are treated anterior cunning to cunning, lower anterior are treated root stems. So we have to take a bite smile also. You have to ask the patient to bite fully and smile. And we have to take 2 photos. Ask the patient to bite fully and keep a scale here from the subnasal to the chin. Make a mark here with pen and keep scale and take 2 photos. We can call it as a scale pictures. 2 pictures we need. PD at occlusion. Here the occlusion is reduced because of attrition. And ask the patient to relax and then take another immediate rest. Okay. So there will be a lot of difference between the immediate rest and immediate occlusion because of attrition. Because of attrition of lower anteriors. While there is lower anterior attrition, anterior chewing pattern. So the more attrition means there is a long years of anterior chewing. They are so much attrited till the gingival level. There is it means lot of years he is living without molars and using only the anteriors. So you can expect lot of bone loss in the molars also. Okay. Gradually what might have happened is slowly this segment has supraerupted also. Okay, dentoalveolar supraeruption as attrition happens. You can see the canine has lost its normal contour. The incisors this side 2, 3. Okay, so this is the canine. See the amount of attrition. Very bad. Okay, so when we checked the vitality, the canines are not vital, right?
Yes.
So they are also not vital. So non-vitality reason is not only decay. What is another reason? Attrition. Okay. So wear and tear is also a reason for the tooth getting non-vital. So our plan is going. You can see the periapical. Can you see a lot of sinus opening here? And there is a sinus opening in T1 also. T1 is completely breakdown. So our tentative plan is lower full mouth. This is the 3D deformated view. Okay. You can see resorption of mandible, distal mandible, and also supraeruption of from 6, 7, 8. Anyway, we are going to give only 6, so you don't have to worry about the 7. This side 7 as supraerupted. If needed, we may do some mild anomaloplasty for upper premolars and molars. There is severe resorption of mandible on both sides. There is periapical cystic lesion in the premolar, in the lower anteriors, everywhere. Okay. So we have to do alveolar plasty till this lesion better. Okay, and remove this bone also. So this 3D deformed view will give you a fair idea about the level of alveoloplasty. Now we have to plan for implants in the interforaminal region and in the distal mandible region. Okay. So there are two regions, one is the interforaminal and the other one is the distal mandible. First we will see the distal mandible. This is the right mental foramen. Okay, just distal to the mental foramen. So this is the canal. Okay. So what is the length available? We will see. Around 6 mm. If you leave 1 or 2 mm safety distance for canal, you may get 5 mm. Okay. So what to do? We will see in the 6th region. So the 6th region, the mesial root of 6th region, not only the ridge is thin, but also the canal is here. Okay, the canal is here. So the length available is around 5 mm, right? Okay, we are going to the almost 7th region. The important feature is there is no significant myeloid ridge. There is no, so that is the problem. So this is the canal. It is around 5 mm. So only 5 mm bone exactly from the top of the nerve. So you have to keep 2 mm safety distance, no? Then you will get only 4 mm. And doing lingual cortical also is not very much favorable. Okay. We will see the left distal mandible. So this is the first molar area, right? Probably this is the canal. Okay, not this one. Canal is here. But naturally the patient has the higher canal. And apart from that, lot of bone resorption. Okay. Here also around 5 mm only. So this is a difficult situation. Now we will see the distal root of 6. Okay. Here the thing is, this is the canal. This is the myeloid ridge. But the canal is above the myeloid ridge, right? See, if the canal is here, we can place the implant from here to here. Okay, but the canal is probably above the myeloid ridge. And if you see, especially the left side, you can see there are 2 canals running here. Okay, can you see the white line here? Okay, that is one canal. I don't think it is a marrow space, no, which runs with a thin white line. And there is one more canal running here. Can you see? Here, from here. Okay, the upper canal is coming out as metal foramen here. Okay, but the lower canal is not coming out, it is coming inside the bone. Whether the lower canal is a real canal or marrow space, that doesn't matter, but the upper canal is a real canal. Okay, we cannot consider the lower canal as the canal, right? Because the upper canal only comes out as the mental foramen. So it may be a 2 canal situation or a 1 canal situation, but whatever the situation is, the canal which comes out as the mental foramen, we have to take it real, but the amount of bone remaining above the upper canal is very less. Okay, you will see the molar area, distal one. Okay, so now you got a 2 canal. Okay, as I already told, maybe the lower canal may be a real canal or a marrow space, but it doesn't matter. But the upper canal is above the myeloid ridge, which is very rare, right? Very rarely you see. So lingual cortical engagement is out of question. Using only the crestal bone is also not very much favorable, because if you give 2 mm safety, you will get only 3 mm bone, which is not good. Now we'll see the 7 region. Okay, 7 region, there is no myeloid ridge, or probably this may be the myeloid ridge, we don't know. Okay, or there is no myeloid ridge, right? Here you cannot do a lingual cortical engagement, the bone is very less, right? So using distal mandible on left side is out of question. The right side also, there is no significant myeloid ridge. We will trace the nerve in right. You can see the right side. This is one nerve, right? This is one canal. Coming very clearly, this is the one which is coming out as mental foramen. If you see canal, there is one more. You can see here. No? Can you see a white line? It is also coming till here. Both sides we are seeing 2 canals. One is upper and one is lower. The lower is, whether it is a canal or bone marrow space, we cannot really tell unless we take a biopsy, or we have to see literature, variations, and we have to correlate with the literature somehow. We have to read some articles, put it in that to the list. Okay, so this is the 6 region, probably distal root of 6. Okay, there is no myeloid ridge, no proper crestal bone. The bone is here only 5 mm. Even the top 2 to 3 mm is thin, right? Even the width is not good. So in the 7 region is more worse. Okay, so using distal mandible is not favorable in this situation. So we have to plan only interforamina. Okay, luckily interforamina bone is somewhat good, even though there is periapical lesion. So first we will plan the anterior nucleus. We will finish the easiest one first. Okay, so we will be placing 2 implants just adjacent to the midline. Okay, then we will come to the premolar implant later. Okay, so if you see here, this is the lesion end. So till this here we will do animalplasty. After that you can place implant straight Okay, there is no need to place implant like this. If you place like this, you will perforate and come out. So better like this. Okay, and you can place up to 13 mm or 14 mm implant. Diameter is 3.75 or 4.1, whatever it is. The bone quality is very good. It's 1200. So better we select a smaller diameter. Right, to select a bigger diameter and difficulty in inserting. The implant will lock in between, right? So this is 4-1 region. So 4-1-4-2 region. Okay. 13 mm implant will be a right choice. Probably a lesser diameter implant. 3.75 is enough because the bone quality is very dense. Even intramedullary bone is similar to a cortical bone. Intramedullary bone itself is 1500. Now we are going to the premolar implant. If you put the premolar implant straight, then there will be a lot of cantilevering because you have planned not to place a distal implant. So definitely it is better to use a screw retained implant. Okay, we will be using a screw retained single piece implant and we will give you a titanium bar with cantilever. So if you place the implant straight in the first molar region, first premolar region, there will be a lot of cantilever. If you tilt it slightly distally, you are getting some more arch space and you may reduce the cantilever. Okay, maybe 3.75 into 13. We will remove this. So clinically what we have to do is we have to drill just anterior to the mental foramen. The tentative rule is we start the drilling from here, right, from the above the mental foramen and tilt it anteriorly. Okay, so when tilting anterior there is a simple rule which if you follow you can avoid damage to the mental nerve and the anterior loop of the mental nerve. So you have to anteriorly 5 mm. It should be 5 mm. But here if you see it is around 4 mm, right? Okay. So from the mental foramen 5 mm should be our implant axis. Okay, so during intrasurgically we have to do this. We can use even a pencil also. Okay, so whatever tilting you are getting by following that 5 mm safety rule, you can tilt it. And of course you should not hit the midline implant. So that much safe implant you can. So we are starting the drilling from the second premolar. We are avoiding the first premolar and we are tilting very good mesially. And we are just keeping the implant just buckled to give a fair idea. The same direction we will be placing the implant inside the bone. So from the mental foramen to our implant drilling, it should be 5 mm. The drilling point may be above the mental foramen or just in front of the mental foramen. Okay, we will decide. Okay, we will measure here. From here to this tree. Almost like 45 degree tilt we have to do. Now we will plan for the left side. So I am placing first a straight axial in the first premolar, but it will produce a lot of cantilever, so we are starting from the second premolar and tilting easily, so we can reduce the cantilever in the our titanium bar. Just I am bringing it buccally so that we will understand how much close it is to the mental foramen. It is close only. Okay. So we have to tilt it some more easily. Okay. Better to use a smaller diameter implant so that closeness to foramen can be. This is the ideal. Okay. We'll say 360 degree. Unfortunately, there is a anterior extension of the inferior alveolar canal also is coming. We cannot avoid that. Okay. Almost like 35 degree. So the key is during surgery you have to expose the mental foramen, mark the mental foramen, and in front of it mark with the pencil 5 mm, and that is the drilling. Okay. So using tapering implant, it will reduce the risk furthermore, because crustally it will be wider, but as it goes apically the diameter will become less. If you use a parallel implant, no, then the risk of damaging the mental loop is more. So only 4 implants, all 4 implants are essential and important. So we have to do very slowly and carefully. So first thing is we have to take 3 photographic records. One is the bite smile photo, using scale to record the immediate occlusion and immediate rest. Then pre-medication, then you can go for bilateral blocks, long buccal nerve and maternal block and additional implantation. Straight out. Apart from this, now we will add abutment and see where the abutment is coming out. So the exit is around between premolar and molar. Okay, so we have told the patient we will give only premolar to premolar, right? In the provisional processes, later during construction of durable process, we will give 1 molar. Okay, and there is one more option also to deal with the situation. That option is you can do. No, not PSA. You can. What option? Can you yes. Yes, you can do. We'll see whether it is feasible or not. We will remove this implant. So exactly in the mental foramen it is like this, right? Okay. So we have to curate this nerve and push it distally. So to push it distally, you need to remove this segment of bone, right? Logically. Okay, so we are curetting mental foramen with the mental nerve from the mental foramen. If you cut a 5 mm block of bone here, so there will be empty space, so the entire nerve, it will come distally. So how much thick this bone? Is it very thick or very thin? If the nerve is very close, the more it is close to the buccal bone, the more it is easy, right? The more it is towards the center or more it is going towards the lingual, you have to remove a lot of bone. Risk of damage to the nerve is more. So we will see necessity. So this is just distal to the mental foramen. So you have to remove this block of bone, and we will remove this mental foramen away. So this full area you can use it for implant. Okay. So this bone is almost 1.5 mm bone, right? Still more distal, we will go and check. This is about 3 mm behind the mental foramen. This is a very cortical bone, right? You have to cut this cortical bone, but at the same time you should not injure the mental foramen. See, if this bone is very thin, then it's an easy situation for doing another position. It is better we should have a piezo if you are planning to do this. No, mallet is not working. Mallet won't work. Okay, so up to 3 mm we can do. Beyond that, no, it becomes so very much into the lingual side. This thickness is increasing more. See here, this side the difficulty is the mental nerve is very thin, diameter is very thin. If it is very thin, then very risky matter. Okay. The more the cancellous bone, the more it is easy to curate it out. Okay. So our final plan is we are planning for all-on-4 type with single piece multi-unit type. Multi-unit implant with the titanium bar with the cantilever, giving only premolar. Then during the durable process we will be giving molar. Okay.